And what to speak today about is angioedema, and comes along with angioedema is hives, which is urticaria. But there are some advances that have been made, especially with hereditary angioneuronic edema, and there has been some advances made with urticaria, and I just wanted to discuss a little bit about that today. So here we go. All right. So if you take a look at hives and angioedema, you see that most patients will present with urticaria alone. 50% of patients that have allergic reactions to something will present with urticaria, but 40% will develop urticaria and angioedema, and then 10% of the population presents with angioedema alone. And I think most of the practitioners are a little bit more concerned when they see angioedema alone. I think it's a little more scary when patients only develop angioedema. They say, why is it that the patient's only developing angioedema? Why do they not have hives? And the truth is we're going to see that angioedema is a little bit different than urticaria, and it should be approached a little bit differently. Okay. So first of all, what's the difference between urticaria and angioedema? Hives generally involves the superficial dermis, where angioedema is more in the deeper dermis. So when the patients have hives that's more superficial, they're mainly going to get itching, the redness, the swelling, where if you have angioedema, instead of getting more itching, you get more pain. Sometimes the patients complain that it's burning. Now, if you have both, then you can have both of those symptoms. But the only difference really is that angioedema is really in the deeper layers as opposed to hives, which is more superficial layers. Okay. And with the urticaria, the patients mainly present with pruritus, elevated papillary plaque-like elevations of the skin. And this is important because a lot of times we get patients that have, let's say, what may be erythema multiforme, where they get target lesions. And sometimes hives do look like target lesions. In general, not always, but in general, if someone's going to have hives, the lesions should last less than 24 hours. So you have someone with lesions that are lasting more than 24 hours, let's say 3 or 4 days already, then you say, whoa, this may not be hives. And certainly if you want to diagnose erythema multiforme, which sometimes could be with the target lesions, it could be hard to tell when someone is on a medication, you're trying to decide whether it's hives or not. I've had plenty of patients come in and the practitioner didn't know whether it was really erythema multiforme and target lesions or it was regular hives. So the first question I asked the family is, how long do each of the individual lesions last? If the individual lesions last less than 24 hours, there's no way it could be target lesions. If they're lasting a few days, then I say, oh, maybe it's really not hives. If it's more than 24 hours, then you have to worry about other problems, like you might have a vasculitic type of lesion, you may have contact dermatitis, but it's less likely to be hives once it's lasting more than 24 hours.
I have a question.
Yeah.
So say they develop some sort of skin lesion and they do take an antihistamine and it resolves, but if they then don't take their second dose of antihistamine, the lesions come back. So they respond to antihistamine but persist for longer than 24 hours if they have a break in their treatment. How would you kind of use that rule of thumb to shake that one out? Okay.
First, let me just add, anyone can ask any questions at any time. I'd rather answer questions than talk about what I want to talk about, so you can interrupt me like Jill already did. So Jill's question is if you treat somebody and they respond, and then the lesions come back. So when I mean that the lesions last 24 hours, that means that individual spot that they have is there, and that individual spot will disappear within 24 hours, and then it might come in different areas. In general, that's what happens. The patient will respond to the antihistamine, but then it will come out, but it typically comes out in a different spot. And Jill brings up a very good point, in that if the patient responds to an antihistamine, there aren't hives. All these other lesions are not going to respond to antihistamine. So if you have a vasculitic lesion, you had erythema multiforme, it's not going to respond to an antihistamine. So that's another good way of telling you whether you're dealing with hives or something else. But if you respond to antihistamine and it comes back again, that's hives. and typically does that, typically will come back. Okay, so I spoke, I don't know, maybe a year and a half ago. I always like to show the pathophysiology of allergic disease because it reminds us what to expect. And in order to make IgE, which is the antibody you need to bind to a mast cell to have a true IgE or type 1 allergic reaction, you need to have exposure. So what tends to happen first is the allergen gets picked up by what's called an antigen-presenting cell. The antigen-presenting cell processes the allergen, it puts it on an MHC2 molecule, then it starts presenting it to naive T cells, and the naive T cells then stimulate other T cells to secrete interleukins, and when you secrete interleukins 4 and 13, it stimulates B cells to become plasma cells, and plasma cells make IgE, and IgE goes around the circulation, and once you have IgE around the circulation, it lands on a mast cell, and once you have IgE sitting on a mast cell, with re-exposure, a person could have an allergic reaction. So the theory is, and the theory is true about 98% of the time, that if a patient hasn't been exposed to an allergen, they shouldn't react. But we've seen plenty of exceptions to the rule. We've seen patients who the mom's got a peanut allergy, and Johnny's been given the first time a little peanut butter, and they have a reaction. The mom's convinced it's the first time, and it could happen. It does happen that way. And we know the kid hasn't been exposed intrauterine because the mom's got a peanut allergy herself. So the rule I'm telling you is a general rule that doesn't apply all the time. So here's, like we just said, you had an antigen-presenting cell that presented the allergen to naive T cell, stimulates T alpha 2 cells to stimulate B cells. B cells become plasma cells to make IgE. The IgE goes around the circulation. But you see with all these interleukins going on, you're also stimulating mast cells and eosinophils, and you need more mast cells and you need eosinophils for the later reactions. When you're dealing with other types of reactions, you could sometimes stimulate the T alpha 1 pathway. So if you have a contact reaction to, let's say, nickel or poison ivy, you stimulate the T alpha 1 cell to stimulate the T cells, and then you get a contact reaction that way. That's a non-IgE reaction. But we're dealing with IgE reactions, we're dealing with stimulating the T alpha 2 pathway.
Sorry, that other thing that you said is very interesting. Do any of these interleukins or IgE or does any of that cross the placenta?
So IgE shouldn't cross the placenta. I don't think anyone's studied whether interleukins cross the placenta. IgA and IgG definitely crosses, but I don't think IgE crosses. I did want to say something, and okay, let me see. All right. Okay. Oh, we need the eosinophil to cause the inflammatory reaction. Okay. And you see now, once you have your IgE sitting in the mast cell, the allergen comes along, binds two IgE molecules, causes the mast cells to degranulate, which releases histamine and other chemicals. I'm going to show you the next slide, which causes your reaction. If it's in the nose, it's sneezing, rhinorrhea, and congestion. If it's in the skin, you're going to get vasodilatation, and the fluid comes up to the surface, and the red cells come a little close to the surface, and that's why you get the hives. The other thing about hives, if you stretch the skin, you'll notice that you could make the apparent rash disappear. But what's important, and then, by the way, once you have your allergic reaction, then inflammatory cells come in, like the eosinophil, which causes inflammation, and if it's in the lungs, it causes the airways to become a little bit more responsive. But this is important in that it's not just histamine that's released. It's other chemicals like glucotriol and platelet activating factors, and those chemicals cause exactly what histamine causes. Vasodilatation, increased microvascular permeability, bronchoconstriction, and also causes inflammatory reactions to happen. Why is that important? Because you'll see a lot of times, mom brings in Johnny, he has his allergic reaction, he's got hives or angioedema, and then you give them antihistamines, they don't get better. Why is it not getting better? Because it's not just histamine. If it's just histamine, an antihistamine would work. But you know that there are other chemicals that play a role other than histamine. And then when you bring in the eosinophil releases chemicals like platelet activating factor, leukotriene C4, which again causes what histamine causes. once you have this inflammatory reaction, it can be even more difficult to treat the hives just with an antihistamine. That's where the steroids would come into play. Okay. Now, this slide that showing the arachidonic acid pathway, you don't have to remember anything from the slide, but I just wanted to point out that there are allergic reactions that you have that aren't caused by IgE, okay? And classically now, when I was a resident, we were just starting to use Motrin. It was a prescription. We never really saw allergic reactions to Motrin because we just didn't use it. Now that everybody's buying it over the counter like water, we see many, many reactions. How is it that Motrin causes a reaction? It's not IgE mediated. It has nothing to do with IgE. What it has to do with is the arachidonic acid pathway. You have the normal cyclooxygenase pathway, and you have the 5-lipoxygenase pathway. If you go down the cyclooxygenase pathway, you make prostaglandins and thromboxane A2. If you go down the 5-lipoxygenase pathway, you make the leukotrienes. And as we showed before, leukotrienes play a role with what looks like angioedema and hives. So the mast cells will release leukotrienes, and you'll have your hives and angioedema from the leukotrienes, because leukotrienes do the same thing. If you block this pathway, right, the cyclooxygenase pathway, you can push the 5-lipoxygenase pathway. So if you take non-steroidals block the cyclooxygenase pathway, and we believe prostaglandin E2 actually, when it's made, stops this pathway from going. So if you don't produce prostaglandin E2, you're going to end up having the 5-lipoxygenase pathway stimulated, and you end up getting more leukotrienes. So the theory is with Advil, Motrin, ibuprofen, or all the other non-steroids except Tylenol, when you take it, you're going to cause a reaction that's really mediated by the leukotrienes. The reason it's important for all you have to know is that anything that is IgE mediated, or almost anything that's IgE mediated, the theory could be a test for. If it's not IgE mediated, it's much more difficult. So like for non-steroids, we don't have a test for it because it's not IgE mediated. It's through this pathway. Okay, so the difference between acute hives and chronic hives and angioedema is actually somebody arbitrarily decided that 6 to 8 weeks, if someone has angioedema hives less than 6 to 8 weeks, it's considered acute, and if it's more than 6 to 8 weeks, it's considered chronic. The truth is that in my eyes, I would cut it out at 2 weeks. Why? Because you really want to, in your mind, say, what's causing the reaction? If you haven't figured out, if someone's having angioedema or hives for 2 weeks already, haven't figured it out, that means they're going to more fit into the categories down here, where if it's happening less than a week or so, you may still have a chance of saying, hey, it's maybe one of these things. Meaning, with acute hives and angioedema, most of the time, it's from 3 things. It's a viral infection, food-induced, or medications. Where if it's chronic angioedema, chronic hives, then you're dealing with non-allergic causes. You really rarely have a food or a medicine, and it's either patients developing physical urticarias, which is like dermographism. Either patients, 2% of the population, scratch their skin, they welt up, or they develop other forms of physical urticarias, like pressure hives and angioedema, cholinergic urticaria, exercise-induced, heat-induced, all these different types of physical urticarias. Then you have patients that have urticaria vasculitis. Those patients tend to have really a vasculitis. The difference, again, is that if it's a vasculitis, it's not going to go away within 24 hours. It may last a week or two. Most patients, by the way, that have chronic urticaria, the cause is either idiopathic, you can do every test in the book and you'll never figure it out, or it's autoimmune related. And there's actually a test that we do, but the problem is the insurance companies don't like to pay for it. They fight with you, so we'll fight back. But it's not really worth it to do on your own, because the test for autoimmune urticaria picks up 80% of the cases. Meaning if you had 100 patients that you knew for sure they had autoimmune urticaria, only 80% of those will be picked up by the test in patients. So that's what we do it when we have patients that are frustrated, they want the answer, we'll send the test to say, yes, here's proof you have autoimmune urticaria. But it really doesn't matter whether you have autoimmune urticaria or idiopathic urticaria because we're going to treat them the same way.
So I'm not sure what the distinction really means, because if you look at the physical urticaria, it's really acute. They scratch themselves, it lasts 10 minutes, it goes away, right? And it may not come on unless they scratch themselves. Well, that's the same thing if you're allergic to, amoxicillin.
But those patients tend to have it go on all the time. They'll sit down and with a little pressure, they'll develop hives. So it tends to be...
Well, because they're being exposed to what causes it. I mean, that's the same thing with the acute ones. If you keep giving someone NSAIDs when they have urticaria from it, it'll never go away.
But most of the time, eventually someone figures that out and they can do something about it. Most of the time you can figure it out and say, you know what, I better stop taking the motion. Where if you have dermographism or pressure-induced hives and angioedema, you really can't do much about it.
Right.
Okay.
That's correct.
Yeah. Okay.
So with cold urticaria, is there an issue in diving into cold water?
Yes. So I wasn't going to get into it, but you're absolutely right that cold urticaria is one of those rare exceptions that if they have, most times the patient only has urticaria most of the time. You're not going to push them to carry EpiPen. So okay, you have hives, usually doesn't progress to anything worse than that, but with cold urticaria, probably, I think the number is about 60 to 70% of those patients, if they jump in a cold pool, can have a chance of actually anaphylaxis. That's where it could progress. So patients who have cold urticaria, we give them EpiPen in case they make the mistake of jumping into a cold pool. Yeah.
When you say food-induced reactions, what is the longest expectancy hives from like a exposure?
So in general, it really should be a day or two, maybe 3 days. If something's going on long and long, it's very unlikely a food's going to be lasting for more than just a few days. And in terms of medications, in the pediatric population, NSAIDs is our biggest problem because patients don't even realize. Like I had a teenager playing football, and he was reacting to different NSAIDs. And it became a problem because he had nothing else to use. Every time he played football, he needed to use them. Anyway, we managed with him, and the mom, it was a very complicated case, and the mom actually asked me at the end, what would you do, doctor? It was a very complicated story. I said, do you really want to know the truth? I said, I wouldn't let him play football. She wasn't happy. Okay. All right. So when you're dealing with foods, if someone has angioedema and hives, you really want to go with the money's at. A lot of times we'll get patients from the general practitioner who will have sent 1 million texts on them, and it comes up that John is allergic to Brussels sprouts or broccoli, and then I said, Mom, when was the last time Johnny had Brussels sprouts? Oh, he hasn't had it. So when you're thinking about foods that you're worried about, you want to think about, the main ones. So if you're dealing with older kids, it's peanuts, nuts, fish, and shellfish. When you're dealing with an infant, it's milk, eggs, wheat, soy, and you all know that contamination very commonly happens in restaurants. So once the patient has a reaction in the restaurant, it becomes more complicated. And viral infections can last for weeks at a time, as opposed to foods that happen for just a couple of days, maybe 2-3 days. Okay. All right. So this is probably the most important slide that I can convey to all of you. The most important way to diagnose the cause of hives and angioedema is the history. Okay? If you get a good history, you should be able to figure out where to go with it. A lot of times, however, the patients will forget they took a pill, they were on an antibiotic, or something like that. So if you ask them a few times, so they come in a couple of times already, and you ask them, is it possible you did this? Is it possible you did that? And all of a sudden they had their sister's Chinese food that she brought or something. It may take more than one visit to figure it out, but after 2 visits, you should be able to figure out. And if it's a food, it really should be picked up on the first time that they come in or the second time they come in. And you can find out that Johnny had a fever the week before, he was vomiting, he had diarrhea, It had what clearly seems like a viral infection, and they didn't give any medications. There were no other foods. Then you know. And the numbers in the articles quoted that 70–80% of acute hives is from a viral infection, where 30 years ago we used to say, oh, it was always from a food or medicine. Actually, 70–80% of the time it's really from viral infection. And this is very important. Never send immunocap tests, which people are still calling RAS tests, which most of them are not RAS tests, indiscriminately, especially panels, because patients are overdiagnosed. I can't tell you, I just had one last week, came in with lists and lists of foods that they're allergic to. If you just listen to the story, you say, okay, Johnny had whatever he had, and you want to send for a test for mushrooms and broccoli, whatever you want to do, that's fine. But when you hit those panels, you get everybody in trouble. Then they come to us, my nurse practitioner or PA or doctor, whoever it is, sent these tests and look at this. Johnny's allergic now to peanuts, and he's allergic to shellfish, and he's allergic to all these things. And then we have to try to figure out whether there's really potential for an allergy there. So it's not good to hit panel. That's the worst thing. Then they come in also with, oh, look, you know, it's very rare that hives and angioedema can be from the family dog. It could be, but it's very rare. But when you hit panel, then the parents come in to me and say, oh, look, Johnny's allergic to the dog. And because they hit panel for hives, and then comes up the dog test is positive. Then I have to convince the family that they didn't have to get rid of the dog, and then they get really upset.
Can you test for humans that way?
Yeah.
Dog,
Yeah.
human, frog.
What do we do when we get new patients who come with a list of multiple allergies that we're suspicious of?
You got to really listen to the story and say, does the story correlate with the test? That's our job, is to sit for hours with the patient, okay? Yeah. It's always the peanuts and the nuts and it's the pets, and we go through it, you know, look. Johnny was eating the peanuts and the nuts before September 1st, and nothing was wrong with him. He had a test on September 1st, and he was positive of the peanuts. Then we have to convince the family, even though the test says you're allergic, you're really not allergic, you're eating it fine. The problem we have is that if they have a 3-year-old who sent up peanuts and nuts, and then they send that test, and then I have to deal with that test, like, is Johnny allergic or isn't Johnny allergic? And I have to scratch my head and say, I don't know. Now we have to do a challenge, and then, you know, all the anxiety builds up. Okay, so when you're dealing with hives...
Can I ask you a question about that first?
Yeah.
So, using the example of using both examples, this is mostly the case of hives. Like if you're talking about someone with like respiratory and stuff like that, you should be testing them for the dog.
Oh, absolutely. If they have a dog, you should be testing them. If they don't have a dog, I'm not sure if you necessarily have to test for the dog, unless the neighbor has a dog. You know, they go at the neighbor's house. Right?
Okay. I guess I'm trying to get your meaning, which is that if you tested the person for allergies and it came up positive that they're allergic to dogs, then it doesn't matter because they don't have a dog?
I will only test if it's clinically relevant.
Okay.
Okay?
I think.
All right. So, moving on. So, in general, when you have hives and angioedema, we're going to start off with an antihistamine to treat them. And this is very important because if patients have angioedema with their hives, angioedema tends not to respond well to antihistamines. Those are the patients that they usually come to me. They've been on a few days of antihistamines and it's not working. And I just say it's not going to work. They're going to need to be on a steroid. If a single antihistamine doesn't work, then you could either bump up the dose, you could double the dose, triple the dose, whatever you want to do, or you can add a second antihistamine. And then with acute hives, certainly it's totally okay if they're not responding to put them on some oral steroids. Most patients will respond to oral steroids where they may not respond to an antihistamine. And we have the older generation diphenhydramine, which is benadryl hydroxyl, which is Atarax, and the newer medications, loratadine, fexofenadine, cetirizine, and levocetirizine. The older generation medications are fine, just they're going to cause some drowsiness and some side effects. The new generations last a little bit longer. The truth is that you probably shouldn't be using lorazepam unless the patient says it works really well, because when the original studies that they did, it barely passed the FDA standards for passing, meaning placebo was like 30% of patients or 35% of patients got better. They were like at 48% of patients. So it barely passed, and usually the others are going to work a little bit better. Cetirizine and levocetirizine are the best, although the cetirizine you get a little bit more drowsiness than you will with all the others. And you all know that the sedating ones, the older ones are sedating and can cause more side effects. You can get some anticholinergic effects. The newer ones are going to last a little bit longer without the side effects. Okay, so if you're dealing with someone who's got chronic urticaria, angioedema, all these different groups decide the best approach. This is from the British Society of Allergy, but the American Academy of Allergy in this country has their own recommendations. And I think any one you want to follow is fine, whether you want to start with a non-sedating and give a higher dose of the non-sedating, like you can start with cetirizine and give them 10 milligrams to start. You can give them 10 milligrams twice a day, or if you want, you can give 10 milligrams of cetirizine, and then you can give them Benadryl or hydroxyzine at bedtime. You can even try anti-leukotrienes. My own personal opinion is that I haven't seen it work well, but theoretically it should help. But the patients that have chronic hives, we end up having to go to other things, the ones that fail everything, which is either cyclosporin or prednisone. So in the pediatric population, we don't have too many patients that we do that with, but occasionally we put them on a low-dose steroid every other day for a while until we can see if we can get it under control. But what's new is that omalizumab, which is Xolair, was approved for asthma, I'm not sure, maybe 12 or 14 years ago, somewhere around there. And someone decided that maybe it would work for hives. Why should it work for hives? We'll talk about it. But for asthma, the theory is that if it's an anti-IgE antibody, it can grab a hold of the IgE, prevent the IgE to land on the mast cells, and prevent allergic asthma. It turns out that it works for asthma that's allergen-related, allergen-induced, or it works for asthma that's not allergen-induced. And they started realizing that maybe their theory, why it works, isn't the true theory. And the truth is that there are anti-inflammatory effects. It's kind of complicated that we won't go into. But if someone asked me how it works, I would say we're not really sure how it works. But if it turns out that it works for asthma and it works for hives. It's approved for patients who are above 12 years of age. We have to give the patients an injection. That's the unfortunate thing. They have to come in every 4 weeks. It's approved for 12 and above. It's a very, very expensive medication. So when we're dealing with angioedema and hives, we say, what are the risks and benefits of going on that as opposed to the alternatives? So the alternatives of stronger cyclosporin and prednisone, cyclosporin and prednisone, the side effects there are worse than with omalizumab. So that's why most allergists, when they have someone above 12, might consider giving the patients Xolair. The real main side effect that people worry about is that 0.2% of the patients that receive it may eventually develop an anaphylactic reaction from it.
When would they get that reaction?
So very good question. Do you know more than everyone else?
No.
Okay. It turns out, you're asking a very good question. You would think when someone gets an injection, within an hour or two, they're going to have a reaction. And the truth is that most patients do react within an hour or two. But there are patients that have reacted like 3 days later. So that's why when we give it, we make sure the patients wait for 2 hours in our office the first couple of times. Although you say, well, why don't you make them wait for 3 days in your office? But it's not practical, so we don't make them wait. But there have been reported cases even like 3 days later.
Do they all have EpiPens at home?
So most of the patients have EpiPens. Yeah, it's probably a good idea if you're going to use it, well, you probably shouldn't use it, but if someone does use it, they probably should give the patients EpiPens. Okay. So this was the theory why it worked. Here's your IgE molecule, right? This is the FAB region, this is the FC region, and this is the omalizumab. So the omalizumab would bind to the FC region over here, and that if it bound to the FC region, now this IgE molecule couldn't bind to the FC receptor on the mast cell. And it's known that it actually does this. It prevents Ig from binding to the FC receptor. But again, even patients that don't have allergen-induced asthma, it works. And Hive patients who have most chronic populations that we're giving it to do not have any Ig involved with the reaction, but it seems to work. Yes?
The insurance company still insisting that you have a sky-high IgE before they'll approve?
For asthma, you just need to have 30. For urticaria, you don't need an IgE level for that. So if you give the diagnosis of urticaria angioedema, you don't need a level. So omalizumab binds to Ig to lower free Ig levels. Subsequently, Ig receptors, the Fc epsilon receptor on the cells, downregulate, and we believe if you downregulate the cells, you're going to end up having less and less mast cells. The mechanism by which these effects of omalizumab result in an improvement of CIU symptoms is unknown. So if you ask anybody how it works for Hive, the real answer is that we have no clue how it works, but it works. Okay. I give the allergy section lecture for the American Academy of Pediatrics board review course. I have a board review course every May, one at North Shore, one at Morristown. So the way those lectures work is that we give questions and then we elaborate on the questions. I'm just going to give you one that's related to this topic. A 10-year-old presents with recurrent angioedema of the extremities and at times his throat. His past medical history is significant for surgery to rule out appendicitis, but no clear diagnosis was made. The family history is significant for a father with a peanut allergy and a penicillin allergy. The most appropriate test to perform is a peanut rash test, a C4 level, a skin test for penicillin, an SPEP, serum protein electrophoresis, or a C1 level. Does anyone know the answer, that they're sure they have the right answer? Does anyone want to guess? Peanut. E? Anyone go for A? Anyone go for B? Anyone go for C? Anyone choosing D? How about E? Okay. So it's all good because most people know a little bit, but not enough. So we're going to educate everybody on this. Now I really want to move over to angioedema. Angioedema alone has the same cause as hives, but other conditions have to be considered. Okay? Angioedema is characterized by sudden onset of swelling of the skin, subcutaneous tissue, or mucous membranes, and you can have it anywhere: arms, legs, bowel, trunk, genitalia. It can happen anywhere. Usually, angioedema, as opposed to hives, can last 24 to 48 to 72 hours. So it does last longer than hives. But when it comes to hereditary angioedema, which we're going to talk about a lot, it can actually last even longer. Okay, so you can have allergic angioedema that we were talking about. It has to do with IgE and hypersensitivity to foods or medications, insect stings, right? But you could also have non-allergic angioedema. And the truth is that when angioedema continues most of the time, when it's lasting a while, meaning a couple weeks, we usually don't find the cause. Angioedema occurs as a consequence of local increase in permeability of capillaries and post-capillary venules, causing local plasma extravasation in response to such mediums as histamine. But when it's allergic, it's histamine. When it's non-allergic, it's mainly bradykinin, and I'm going to show you a little bit about that. Okay. Non-allergic angioedema can be further classified into hereditary, drug-induced, acquired. It occurs primarily as a result of increased bradykinin levels. and bradykinin doesn't respond to antihistamine. So it's very important to figure out what type of angioedema that you're dealing with. And bradykinin is part of the kinin family of peptides that are released into the body fluids and tissue as a result of enzymatic action of the kallikrein system, which I'm going to show you. And bradykinin is thought to be one of the most potent substances in the system because it initiates the release of several important endothelial derivative vasodilatory mediators, such as nitric oxide substance P and prostaglandin. So these are going to cause, the bradykinin is going to cause a lot in the way of vasodilatation. So you don't have to know any of this, but just to remind everybody, how is bradykinin made? You first start out with factor 11, and you go down this whole pathway through the kallikrein pathway, and you end up making bradykinin. What's also important is that the factor 11 cascade breaks off to the complement pathway. This is the complement pathway. You start with C1, and you can activate it, and you get C4, C2, C3, C5, and then eventually you can attack the area where there's inflammation when the whole pathway goes down. You don't really have to know that. But what you need to know is that they are connected, and you need this enzyme, C1 esterase, in order for this to happen, okay? So C1 esterase causes all these different areas reactions to occur, and you end up making bradykinin. And what there is in the system is besides having C1 esterase that allows the enzymatic reaction to happen to make bradykinin, you have an inhibitor. You have a C1 esterase inhibitor. If you're missing the inhibitor, then what happens is the pathway just keeps going and you make too much bradykinin. So hereditary angioedema is a condition where the patients are missing their C1 esterase inhibitor. They have C1 esterase, it's the inhibitor they're missing. And the C1 esterase will stimulate the pathway to make bradykinin. What the patients need is the C1 esterase inhibitor in order to block the pathway from happening. It turns out that that C1 esterase inhibitor is also part of the complement system. So if you're missing the inhibitor, the complement system is stimulated also, okay? And that's important when we talk about hereditary angioedema, because when we come to diagnosing hereditary angioedema, we diagnose it with the complement pathway, although the physiology of the condition has nothing to do with complement. The physiology of the condition has to do with bradykinin. So there's two pathways C1 esterase is involved with. We make the diagnosis with the complement pathway, but that's not the physiology of the problem. The physiology of the problem is that we're making too much bradykinin. So when we talk about, let me just go off and talk about other causes of angioedema other than hereditary angioedema. We have medications, and again, nonsteroidals is a common one we see that where patients will just present with angioedema alone, okay? And then we have patients, we don't really see in the pediatric population that often, but occasionally you'll have a kid who's got a cardiac problem and he's on an ACE inhibitor, but ACE inhibitors are notorious to causing angioedema alone, okay? ACE inhibitors are non-steroidals. How does an ACE inhibitor cause angioedema? It's because the ACE inhibitor is involved not only with the angiotensin converting enzyme pathway, it's also involved with the kininogen and bradykinin pathway. So you need angiotensin converting enzyme to break down bradykinin. If you have an ACE inhibitor, it's going to inhibit the angiotensin converting enzyme, and then what's going to happen is bradykinin is going to get broken down, and you increase bradykinin. And when you increase bradykinin, you're going to get the angioedema from the ACE inhibitors. Okay. There are patients that have angioedema from vibrations. Okay. There are patients that have angioedema from pressure. They can get hives also, but very commonly they'll just get angioedema. They'll get it around their belt line, or if someone's carrying a personal day, or around straps around their bra. Wherever there's pressure, they'll take off whatever they're wearing, and all of a sudden, a couple hours later, they'll develop angioedema at that spot. Okay. Now I want to move on to, this is like the key part of the talk, hereditary angioedema. Okay? Very crucial. When you get a patient who has angioedema, that's when lights should go off and say, oh, this is this is different, or this could potentially differ. And that's when hereditary angioedema comes up. If a patient has hives and angioedema, you don't have to worry about this condition. This condition does not have hives involved with it. They do get sometimes this little red rash with it, but it's not hives. And the way you know it's hives is that patients are going to complain also that they're itching. Patients that are itching and have red lesions don't have this condition because they only get angioedema alone. Okay? So it's very crucial. That's when you should think about it. When it's angioedema alone, it usually presents between 3 and 20 years of age. Very commonly, they'll develop abdominal angioedema. So in the old days, before they did CAT scans with contrast, they would go to the OR, assuming the patient had appendicitis. They would take out their appendix and find that it happened like another month later, and it really had nothing to do with appendicitis. Now with CAT scans, the patients don't get misdiagnosed as much. The C1 esterase inhibitor is deficient. So when that is deficient, you end up having too much bradykinin produced. The C4 is almost always low. Always. It's always low. The C2 is actually low during an attack. C1 esterase levels are low, but there's a version where you have actually normal levels. So there's two major versions. There's actually a third version. And now there's actually treatment. 10 years ago, we had no treatment for this other than using things like oral steroids daily, and if they had an acute attack, we would give them fresh frozen plasma. The patients don't respond to epinephrine nor antihistamines nor steroids. So there really was no real therapy. All of a sudden, maybe 8 or 10 years ago, they started coming out with therapy for this condition. But the answer to the question that I presented before is everyone usually picks, like they did here, that the C1 is low. It's not the C1 that's low, it's the C1 esterase inhibitor that's low. So that was the wrong answer. The real answer is C4. So if you have a patient who you want to work up on your own, who comes with angioedema alone, it's definitely appropriate to send a C4 level. 99% of patients with this condition will have a low C4 level. So if you ever have someone with angioedema alone, it's appropriate to send a C4 level. And I'm going to show it on the next slide, but many times the patients, when they're just starting, they'll have just minor episodes of angioedema. You may just blow it off and say, oh, he had a little angioedema. But once it happens more than once, then you have to start saying, oh, maybe this is a kid who's going to eventually show full signs of hereditary angioedema.
Have you seen any of them in your practice recently, or just is it? It's very rare.
When I was full-time at Columbia, I was part of a couple of studies, so we were taking care of a lot of patients. Now up here alone, I have 2 patients. I have 2 patients up here.
Does this matter? Is it like 2, 3 years old, or 12, 14 years old?
Well, the ones I have now are 20 and 30.
Yeah. Oh.
And it's lifelong, so once they have it, they have the diagnosis for life. Okay. So just to remind you, the same slide.
All the time, or and it just went unrecognized, or it's developed?
It could be that, most patients develop when they're kids, as you're going to see in the next slide. Most patients are diagnosed, or I shouldn't say diagnosed, are having symptoms since childhood. It may take a while to get diagnosed. Most patients present when they're a child. They may not get diagnosed until later on. But they could start out with symptoms like once every 12 months, and all of a sudden, boom, they're having symptoms every 4 weeks. And it's variable. We've had patients who, it's genetic for most patients, so we've had relatives that have the disease and they have some angioedema in the hand once a year, and then the sibling has terrible reactions every 3 weeks. And so it's variable how they present. It's variable how they present. So just to show you again that the C1 esterase inhibitor is all over this pathway, and without that inhibitor, the C1 esterase is going to work overdrive and can reduce bradykinin. And the C1 esterase is involved with the complement pathway, so you're going to end up using up your complement, and that's why the C4 levels are down, and during the acute attack, the C2 levels are down. Okay, so there's 3 versions. 2 are common, the third one is very rare. The first version is where they actually they don't make enough C1 esterase. The second version is they make the C1 esterase, but it doesn't work. So 85% of the patients have the version where they just don't have enough C1 esterase. 15% have a dysfunctional C1 esterase. And the third version is a version that doesn't make any sense, where all the tests are normal. And it tends to happen more with females, so they think it's estrogen dependent. We're going to leave that alone. Okay. So what's the prevalence? People are saying, how often is this seen? It's probably about 1 in 50,000. There's no difference in male or female, but it's triggered by physical or emotional stress, infections, fluctuation in hormones, pregnancy, very commonly by procedures. So that's why when the patient's having a routine dental procedure, we'll tune them up before they have a procedure, or if they're having any surgery, we tune them up to make sure they're prepared for any procedures.
So in some ways, it's very similar to inborn errors that happen, where in times of stress, where you need that enzyme more, you don't have it. So
exactly. So as we said, the deficiency, 85% is there, 50% it's there, but doesn't work. And then the third version is probably less than 1% of the time, where all the tests that you do are normal in patients. And in terms of symptoms, they usually have, we put them into 3 categories. But they can overlap. But a lot of times they'll just present with angioedema, the face and hands, arms and legs, that's it. And then a lot of times we'll have patients that just present with abdominal pain, whether it be the intestines or the stomach or the bladder, the kidneys, so they get abdominal pain. That's where they get misdiagnosis of appendicitis. And then the third version is it involves their upper airway. If you take a look, patients do present with the same thing all the time, but unfortunately, 70% of the time, the patients will eventually have their upper airway involved. So that's why it becomes important, because their airway can collapse, and then you have a real terrible emergency. That's why these patients, even though they have a symptom once a year, they really should be prepared to know how to treat it. Okay. All right, I think we can skip this. We're going to skip this and talk more about this. 40% of people with HAE experience the first episode before the age of 5, 75% before the age of 15, and like 85% before the age of 20. Okay? Patients typically experience minor swelling in childhood that may go unnoticed or just, pushed off, don't worry about it. But then as they get older, they start presenting with worse symptoms. And 5% of adults with HAE are asymptomatic while carrying the C1 esterase mutation. So there are patients that have it, they have the deficiency, but they never have any symptoms.
how common is just angioedema that's not without urticaria? Someone comes in with a little swelling and it goes away.
There's no number, but the odds are if someone has angioedema alone, they're not going to have this. But if you miss it, it can be pretty bad because in theory it could be life-threatening. So that's why I say it's appropriate. If anyone has the angioedema alone, maybe the first time you want to push it off, it's fine. But if someone has 2 episodes of angioedema alone, you really have to you just send a C4 level. 99% of patients will have an abnormal C4 level, so you don't have to send them for C1 esterase level. And you can make a mistake. If you do, you can get yourself in trouble because if it's not put on ice, you're going to get an abnormal result. Plenty of times we get patients referred that have an abnormal C1 esterase level, the C4 is normal, and all I do is I just tell our lab, send it on ice, and it comes back normal. So the only thing you have to remember is the C4 level. And if you're taking the boards again, this is the common question that they ask. The screening test is the C4 level. Yeah. Okay. Moving on with symptoms. They usually develop swelling that progresses over 12 to 24 hours, but where with regular angioedema lasts 2 to 3 days, this can last 5 days. And they don't respond to antihistamines, prednisone, and epinephrine. They're periodic episodes that can happen every week, every month, every year. Everybody's different. And in the pediatric population, it's less frequent, but eventually, as they get older, they're having more frequent symptoms. And we talked about precipitating factors, and I want to give some time to the speech. I want to just go through treatment. In the old days, again, there was no medication that was approved for this to treat it. But we used to use, as the patients got older, we used to use danazole or stanazolol, which is an angiogenetic steroid, which actually prevented attacks. However, you have plenty of problems with that. You could look on the slide. You got plenty of problems with this, so we really didn't like to use it. But now, what's happened is that for some crazy reason, a lot of different groups decided they were going to find a treatment for this, and there's a lot of different therapies. There's therapies to replace human esterase, okay? So you have companies that are making Cinryze or Rucin, which is actually recombinant C1 esterase. The Cinryze product is actually pooled from thousands and thousands and thousands of patients. The truth is that there's really never been a report of anyone getting any HIV or any other hepatitis from it, but it's pooled, so it scares people. This company just got approval for their recombinant one, so now people feel better if they're going to use a recombinant one. There's still a fortune of money. Treatment with these medications are basically $6,000 to $7,000 a month. So it's very, very expensive. They also developed kallikrein inhibitors. So if you inhibit kallikrein, then you inhibit the production of bradykinin. They also developed this icatibant. That's actually at Columbia. This is the one we studied, where we gave patients shots of icatibant. It actually, it's an antagonist to bradykinin, and that also works. None of them work great, but if we have patients that have a lot of symptoms, we'll actually put them on infusions of this C1 esterase, and we get them prepared with injections that they could use if they have an acute attack. So the injections of Kalbitor, which is the kallikrein inhibitor, and the injections of icatibant, which is the bradykinin antagonist that patients can have with them, and someone who's capable can give them an injection if they have an attack to prevent the airway from collapsing. And I'll stop here right on time. Where's Jill? Is Jill here? Okay. And anyway, I'll take questions until I get thrown off. Yeah.
So hereditary, can it be brought on by steroids, like a NSAID, or no?
Oh, a very good question. No, NSAIDs tend not to bring it on, but ACE inhibitors do, and sometimes birth control pills do. Very good. Excellent. Yeah.
Question, to mention it, Zyrtec, 10 milligrams BID for larger. Can you do that indefinitely? Are there any issues with that at all?
You can do it indefinitely. The FDA, whenever the FDA puts something over the counter, they're basically saying that it's hard to kill yourself by taking it.
Yeah.
So, and all allergists do that. You can take a Lego, an adult person can take a Lego 3 times a day. There are studies that people take 180 milligrams 3 times a day. Yes.
Actually, on the same wavelength with the Zyrtec 10 milligrams BID, is there a time frame to when you can give Benadryl as well?
Yeah, the only side effects you're going to get, especially kids, is that they're going to become drowsy. So if they're not drowsy, you can give them all the Benadryl. And sometimes if they're really bad, you tell them, oh, listen, what, Johnny's so bad, give him some Benadryl, he's going to go to sleep. It's fine.
Is there any role for an H2 blocker?
Oh, excellent questions. Any role in H2 blockers, there's no study that proves that H2 blockers work in hives. Every emergency room, as part of their protocol, someone comes in with hives or anaphylaxis, they have it on their protocol. Theoretically, it should work with someone who has hypotension because H2 receptors are on the blood vessels, so in theory it should work, but it's never really been proven. We used to use it. I started doing analysis in 1990, let's say, and we used to use it all the time, and then we realized it never works. So most allergists aren't spending much time, unless we put them on steroids. Also, we'll say, hey, you know what, give them some Zantac also to prevent them from killing themselves, but we don't really, most allergists don't use it unless we're running out of things to do and we want to stall. So,
You said earlier not to order those allergy panels.
Yeah.
Is there ever an appropriate time?
A panel, it's never appropriate to send a panel. It's always appropriate to say, this is what I think they're allergic to. They had a reaction to whatever, milk, let me send a test for milk. If you send a panel, they're going to just, they may not tell you, but they end up at the allergist's office and we're going through every test. Okay, Johnny was eating broccoli before the test, and he had rash, okay, but broccoli back in his diet, and whatever the food is, just taking on the food. Yeah.
When you do steroids, like for hives or something like that, how do you do a taper? How do you usually?
If it's acute hives, I might just give them 5 days. If it's chronic hives, I can have people on it for weeks if I need to, until I get them over to something else. So we have older patients. The younger kids, we really don't want to give them cyclosporin or prednisone. But we have older teenagers and we have adults that we have them on a couple of months of, let's say, prednisone, and then we start talking about putting them on to the omalizumab or to give them cyclosporin or whatever. But acute hives, 5 days should be good.
And
but there are 5 days that don't respond. They come in after they've been seen by the general practitioner, and the 5 days didn't do the trick, and then we have to give them longer. But in general, it's appropriate to give them 5 days for the initial event. That would be appropriate.
Same as you don't have to taper it, like same as.
No, everybody should know this, that if you give prednisone less than 7 days, some people say 10 days, some people say 14 days, but certainly less than 7 days, you don't have to taper. Why do people taper steroids? Because if you take it more than 2 weeks, you might shut up the adrenal glands. Less than 7 days, you're not going to shut up the adrenal glands, so you can go from 40 milligrams a day for 7 days and just stop it. You're fine. If you want.
I'm more so the opposite, like, is there any method just giving them 1 dose or do, 3 doses or?
If you're going to start, it's probably better to just do the 5 days, because you're going to give it 2 or 3 days, it's going to come back a few days later, you're going to restart it again. Yeah.
Contact dermatitis, when you put the kids on the prednisone, I was always quick to wean it down.
If you're dealing with someone who's got a minor problem, 5 to 7 days is plenty. If you're dealing with poison ivy, that's a different story. Because poison ivy could last weeks. There, it's a different story. If they're case of poison ivy, then you might give them like 7 days of 40 milligrams a day, and then go down because it's such a bad case. There would be appropriate. And I think the people in the back are going to shoot me, so maybe I've got to come off. Thank you very much. What I'm going to speak today about is angioedema, and comes along with angioedema is hives, which is urticaria. But there are some advances that have been made, especially with hereditary angioneuronic edema, and there has been some advances made with urticaria, and I just wanted to discuss a little bit about that today. So here we go. All right. So if you take a look at hives and angioedema, you see that most patients will present with urticaria alone. 50% of patients that have allergic reactions to something will present with urticaria, but 40% will develop urticaria and angioedema, and then 10% of the population presents with angioedema alone. And I think most of the practitioners are a little bit more concerned when they see angioedema alone. I think it's a little more scary when patients only develop angioedema. They say, why is it that the patient's only developing angioedema? Why do they not have hives? And the truth is we're going to see that angioedema is a little bit different than urticaria, and it should be approached a little bit differently. Okay. So, first of all, what's the difference between urticaria and angioedema? Hives generally involves more the superficial dermis, where angioedema is more in the deeper dermis. So when the patients have hives that's more superficial, they're mainly going to get itching, the redness, the swelling, where if you have angioedema, instead of getting more itching, you get more pain. Sometimes the patients complain that it's burning. Now, if you have both, then you can have both of those symptoms. But the only difference really is that angioedema is really in the deeper layers as opposed to hives, which is more superficial layers. Okay. And with urticaria, the patients mainly present with pruritus, elevated papular plaque-like elevations of the skin. And this is important because a lot of times we get patients that have, let's say, what may be erythema multiforme, where they get target lesions. And sometimes hives do look like target lesions. In general, not always, but in general, if someone's going to have hives, the lesions should last less than 24 hours. So you have someone with lesions that are lasting more than 24 hours.